Welcome, everyone. Welcome to Addressing the COVID-19 Crisis, an open forum webinar series for pharmacy. My name is Sandra Leal, and I'm the president of the American Pharmacists Association. Today's webinar is supported by the Centers for Disease Control and Prevention. And the topic that we'll be covering for today's webinar is to review recent updates and recommendations for COVID-19 vaccine and other adult vaccines. We have two great speakers today. We have Steve Foster, who's been on this webinar series multiple times, and we thank him. He is APHA's former liaison representative to ACIP. He retired as a captain from the U.S. Public Health Service in 1998 as a professor from the University of Tennessee College of Pharmacy in 2016. He is a national faculty and writer with APHA's pharmacy-based immunization certificate training program and has been a featured speaker and author in many immunization education programs. Dr. Foster has personally trained thousands of pharmacists as immunizers, and through his work with student pharmacists has facilitated the vaccination of more than 10,000 Tennesseans. Thank you so much, Steve, for all your work. We also have with us Mitch Ruffles, and he is the APHA's Chief of Governance and State Affiliates and the Executive Director of the American Pharmacists Association Foundation. He is a nationally recognized expert on pharmacy-based immunization delivery and serves as a national faculty member for APHA's certificate training program. Mitch is a participant of several immunization stakeholder task forces and has assisted numerous pharmacists in implementing immunization services within their practice site. He has also been extremely active during this pandemic. So thank you so much, Mitch, for everything you've done. We have subject matter experts today. Dan Zlot, he's a Senior Vice President of Education and Business Development with APHA, and he brings 10 years of experience at NIH as an oncology infectious disease specialist. And we also have with us Mike Baxter, and he's the APHA Senior Director of Regulatory Policy with APHA. So let's review the format for today's webinar. So we have the discussion with Steve and Mitch for about 25 minutes, and then we will have the open forum discussion where we will take your questions and thoughts as you're typing them in the GoToWebinar toolbar. And then at the end at 1:50, we'll review APHA ongoing activities and what's coming up. So we want to hear questions from you. So please go ahead and use the question field on the GoToWebinar toolbar. We will try to get to as many audience questions as we can. And you will also see the handout on the slide with a live link to the resources mentioned during today's program. Make sure you download that for future reference. And with that, I will invite Steve and Mitch to turn on their cameras and we can get this conversation going. Steve, welcome. Mitch, welcome so much. I'm going to start here with you, Steve, thank you so much for your longstanding service to the CDC's Advisory Committee on Immunization Practices and for your valuable participation in our COVID-19 series. You keep us up to date with the latest immunization developments, and we know that ACIP met yesterday and this morning to discuss recommendations for several routine vaccines. So we wanted to talk to you about that today to see what was covered. So I'll start with the first question here. So what do pharmacists need to know about the committee's discussion on influenza vaccine?
Again, thank you for the invite. This was one of the few meetings we actually had that were non-COVID, so it was kind of nice to be able to hear what else is going on. But with influenza, as you are probably aware, not much is going on. We had very little presentations on it. Our season has been very mild. In fact, they say it's about the mildest we've had in quite a long time, even more mild than last year. The one difference that you can, well, again, last year we had one pediatric death. This is one way that you measure how it is. This year we've had 5, so it's still very low as far as that. So the vaccine, the virus did not circulate as much as we thought. When they looked at the number of cases, they were quite low, particularly in comparison to the number of testings that they did. So it was an H3N2 circulated where it did. It was very, they usually expect that to be more of a serious season when that circulates, but again, it didn't. So there's just not much to predict about it. The only negative is that the vaccination rate was down this year compared to last year. And that's not a good sign because if people get used to not getting vaccinated, it's going to be difficult to keep them going.
Yeah, I was following the flu maps because I was worried. They kept saying it might be a very, bad year, but thank goodness it didn't pan out to be that way. But hopefully people wearing masks and doing the other mitigating things has helped maintain that low. So, but I agree with you. We definitely have to get those vaccine rates for flu up.
Sandra, can I add
Yeah.
something on that too? It's important for the audience to also know that we're in the peak of traditional flu season. So it's still time for people to get vaccinated against the flu. So even though the number of cases are lower than in the past, people can still get it and can have it confused with COVID or other respiratory illnesses. So best protection is to get your flu shot, and it's still time to get your flu shot.
And we have had a few peaks of seasons over the last 30, 40 years in March, so it's not too late.
No, agreed. Yep, I definitely got mine when I could, just like usual. So I highly recommend it. We definitely can't lose focus on that.
One other thing that they did talk about with flu, though, was about a preferential recommendation for the senior vaccine. And so they presented a bunch of the data on what they have. There was like 3,000 studies that they had with it, and they kind of whittled it down to about 40 that actually had data that they could use. And while there was at least one good randomized controlled trial on high dose flu in particular showing a benefit, on the other ones there was some data. In most cases the studies were observational. In most cases they were small studies. So I didn't get a strong feeling that there was going to be a recommendation or a preferential recommendation as of yet. But again, this discussion will be continuing.
We'll definitely keep an eye on that. But no, appreciate the recommendation. So if you haven't had your flu vaccine, make sure you receive it and recommend it to others. Any updates for the MMR vaccine in your discussion, Stephen?
They introduced a new MMR vaccine. I think it's called Priorix by GSK. It's been used for many years around the world. I think it's in 100 different countries. And they are actually bringing it into the United States. So it's not been approved by the FDA yet. So it's just another vaccine that's coming on the market. What they showed was that it's not inferior to what we have on the market now. So it would be just an additional vaccine. They did mention the fact that we are having some measles outbreaks around the world that are being addressed right now. But that was all that was done with that.
Okay.
And so to add to that too is, we're seeing some of the outbreaks that are happening in some areas because we've also seen a decrease in the rates of childhood vaccinations. So that has also increased exposure in communities. So again, there's a lot of effort being done now by CDC and others to try to restart those routine childhood, adolescent, and even adult vaccines, because we're going to see breakthroughs because if the rates go down, people are going to be exposed potentially.
Yeah, no, that's important. An important point to get kids caught up on vaccines and hopefully get them connected back to care if they haven't been doing their routine care. So let's talk a little bit about hepatitis B vaccine. What's the latest on that? And I'll go back to you.
A couple things came out with that. First of all, the hepatitis B vaccine back in November was actually recommended as a universal recommendation. As we know that universal recommendations work a lot better for increasing vaccination rates versus a risk-based recommendation. And we have not seen an increase in vaccination rates of hepatitis B since we actually added the diabetic recommendation, and that was back about, I don't know how long, but that's quite a few years ago. And you would have expected to see that rate go up quite a bit with the number of diabetics we have, and it didn't go up at all. So that's why the discussion came up, is that we need to do more, and so they made it a universal. I might add that I've not seen it printed in an MMWR yet, and it's not in the new schedule. So we just need to wait until that gets printed to say that's a recommendation. But there's so many people out there that need the vaccine, even based on the old recommendations. But we're waiting for that to be published again before we see that. There's a new Prehevbrio, a new hepatitis B vaccine. It's a 3-shot series. It is by APhA, I think it's the name of the company. Wait a second, BBI. That is now on the market. It's a 3-shot series also, 0, 1, and 6 months like the others. It's just it is another vaccine. Their claim is that it has 3 antigens in it compared to 1 in the other one, so they might get a slightly better titers. I will tell you, there's been no head-to-head comparison, so you really cannot. Well, there's been a head-to-head comparison with Injurex, with one of the vaccines, but really you can't look at these vaccines and say one's better than the other based on titers type of thing at this point. So the ACIP has not made a recommendation or preferential recommendation yet.
Sandra, I could add too on the hepatitis B, and Steve reminded me when he was talking about patients with diabetes. We've been advocating for a while now that if pharmacists had the authority, the ability to get paid by Medicare Part B, like boy, for patients with diabetes, which is a recommendation coming out of CDC ACIP, that I think we could increase those rates of vaccination. But unfortunately, pharmacists can't bill Medicare Part B for those vaccinations for patients with diabetes. And so it's one of the case examples that we're using in advocating for that provider status designation is if we're able to bill for, get paid out of Medicare Part B, we can increase the rates of hepatitis B vaccinations in patients with diabetes. So that's just another example for advocacy that you could use in making the case.
Yeah, that's a great point. And I know we keep, chipping away at trying to get those recognitions, but ultimately it helps patient care and public health. So appreciate you using that example, Mitch. ACIP focused on pneumococcal vaccine this morning. Are there any changes or updates that pharmacists should be aware of with this pneumococcal vaccine discussion?
Back in November, they made the recommendations for the change for pneumococcal vaccination for seniors. It's because of the two new vaccines, the PCV 15 and the PCV 20 that's now on the market. And those recommendations briefly was that if you have a vaccine naive patient that's over 65, then you have a choice of either giving the PCV 20 by itself or give PCV 15 plus PPSV 23 separated by 1 year. Or if somebody's not completed the series, you can complete it with that. I do want to point out that they did not make any recommendation as of yet to give those vaccines to anybody that's already completed the series of the vaccine. And by the way, the same thing applies to people under the age of 65 with high-risk conditions. If you remember the two different types of conditions, one was the immunocompromised and the very high risk, and then also those with heart disease, lung disease, diabetes, etc. And again, those vaccines, if they're vaccine naive, can be substituted for that. However, if they've already had part of the series or completed, you can complete the series with it, but if they already had the series, there's no recommendation yet to give them another series on that. So we're waiting to see where that came. Now, to answer your question this morning, it was strictly on the introduction of PCV 15, data on that which is a new Merck product for children. And so we have not yet had a recommendation made. They're hoping that in fact, it's not even approved for children yet. It's before the FDA. They're expecting an approval by FDA within the next few months. And if that occurs, then probably by the June ACIP meeting, they'll be able to make a decision about that. So the main discussion on that was the work group had felt like PCV 15 could be interchanged with PCV 13, whichever one they wanted to use. There were several members of the committee that felt a preferential should be made for the 15, and so those discussions will continue.
Great. And there's a statement that has been made that these new recommendations simplify the process. What do you think? Can you provide any insight into that? Because I don't know.
And I tell you what, we have been so unsimplified with pneumococcal vaccination over the years. We'll see where this goes. It's not simplified yet because we haven't. It might be simplified for somebody who's vaccine naive. When you turn 65, you got a choice of one, getting the 20 or getting the 15 plus the Pneumovax 23. So that's pretty much simplified as well it goes. But until we have everybody caught to that point, or everybody's vaccine naive that we have to discuss with, it's still pretty complicated.
Yeah,
I'm hoping it'll change. And by the way, even to add the complications, there's other vaccines still that they're studying to add more serotypes to it. And so as that continues, things are going to continue to change. And it's good they're adding more serotypes because we still have about 40 to 50% of the serotypes that cause disease are not in the vaccines.
Yeah, it's funny to me. People think COVID's been complicated. I remember trying to figure out this pneumococcal for patients that I manage with diabetes, and that was not easy either. And it just, to your point, there's just a lot more going on. So that's not easy. So let's talk a little bit about the 2022 vaccine schedule, which ACIP recently released for children and adolescents under 18. Can you comment on the 2022 schedule and if there's anything pharmacists should know?
Well, first of all, everybody should have a copy of this, and also keep in mind that it can change over the year, so it's a fluid kind of thing. The main thing for the childhood is that they've added dengue vaccine in there in the childhood schedule. First time we've had that, and that's because it is for certain populations in certain areas of the United States, particularly in some of the tropical islands. So that recommendation they added. Also for the childhood schedule, they added instead of the fourth table that they used to have, which was contraindications, they now have an appendix in there. So they've changed it to be an appendix, which talks about contraindications and then precautions. For the adult schedule, mainly the things I've already said, the PCV 13 recommendations on there for those over 65, the universal hepatitis B. zoster has been changed in the fact that it can now be given in immunocompromised patients. But that's really about the bulk of the changes that we've seen for this year.
Great. Any comments, Mitch? Anything you want to mention? All right. So I definitely want to just let people know we've got the links to these in the handout. So if you want to reference these, you can go through the live links in the handout that's available in the GoToWebinar control bar. All right, so let's talk about case rates in the US, Steve, related to COVID-19. I know we've just kind of had this, crazy peak here, as you can see, but I'll pass it over to you to talk a little bit about where we're at.
It's, I tell you, it is crazy, as you said, and I think one thing that came out significant over the last week or two was what was happening in Denmark. I don't know if you've kept up with that, but they kind of changed how they recorded things. And the change was patients having hospitalized with COVID or patients hospitalized having COVID and not because they're hospitalized, not because of the COVID. So that's changed some of the graphs, and particularly the death graphs that occur in some other countries. So the discussion has been coming on what's going on. As you can see by this one, we've had a really high peak of cases. That's partly driven by the number of tests that are done also. So it's particularly now that we're getting tests that are mailed out to everybody's homes, this whole thing could change too. We don't know, but right now the overall feeling is that the case rates are lower than it's been for a while. Many states, most states, I think, are dropping some of the restrictions that they've had with masks and with getting out and being with each other. What will happen in the future? Maybe that'll make the cases go back up. Maybe it won't. Depends on what the disease is. But right now we are at a low moment again. I think they said something, Michigan, about 1,000 cases a day or 1,000 deaths a day, something in that range. I think it was 1,000 deaths a day, and which is at the lowest we've had. It's still too many, but it's about the lowest we've had for quite a while.
Yeah, no, it's been crazy. I've been following Denmark, and it's just been amazing to kind of watch and see what's been happening there. And they've had much higher vaccine rates than we have. So I hope, we've learned something from that experience, but very interesting to watch what's going on.
And the main thing that we got to realize is change is going to continue with this. So it's not something we can look at this will predict tomorrow. I mean, it could go right back up tomorrow. There could be a variant that comes along tomorrow. So we do know that the Omicron variant that has been circulating has another variant on it too, but it appears that particular variant is, while maybe more contagious, it doesn't seem to be doesn't appear to be any more virulent than the other one. And it also shows that if you've had the first Omicron, then you seem to be protected against the second, which is also good news for the vaccination coverage. But again, we could have a new variant come up tomorrow.
Yep, that's why I still wear my mask in certain areas. I was just on a plane. I'm like, I will never fly without a mask again, not just for that, but for colds and flu and other things too. So I can't recommend that enough.
The other thing that CDC is watching and FDA is watching as well is with the new variant that's starting to show some of the monoclonal antibodies and some of the antivirals don't work as well with it. So they're watching that in terms of the case reports and hospitalizations. As Steve said, it seems to be more virulent, but in terms of severity, it doesn't seem to be as severe as previous variants.
Good. All right, let's talk about immunocompromised individuals, and I'll go to you, Mitch. Over the past month, the CDC has released updates related to the vaccine schedule for immunized or immunocompromised patients. Can you review these recent changes? And this is great, this little graphic to help out with that.
Yeah, and I want to commend one of our APhA staff members, Meg Friday, who has been doing a yeoman's job of every time we send her any of the updates, changes that are coming out of CDC, she's getting them put into the resources that we have. So thank you, Meg, for keeping up on that. And just to tell the audience is that we are updating what just got released earlier this week. It will be updated again based on some of the things I'll talk about in a few minutes. But in terms of immunocompromised patients, it's been something that's been a concern, something that CDC has been looking at in terms of breakthrough cases and what's the protection that these individuals are able to carry forward. And so in looking at that, CDC has changed some of the timing for patients who are considered moderate or severely immunocompromised. One of the guidances that has come out of CDC, as we recall early on, we were so diligent of making sure and checking and looking for documentation of whether somebody is immunocompromised or not. They've loosened that. If somebody says they're immunocompromised, take their word for it and move on. Don't stress about that. But in terms of timing, and this chart shows it really well, where it used to be from the last, I'll call it primary dose, to a booster, it used to be a 5-month period of time. They've now reduced that down to a 3-month period of time. So that's the current recommendation for individuals who are immunocompromised, that they've got that time frame of 3 months. So this chart really lays it out well in terms of the timing. So we wanted to make sure you've got that information and you're aware of the current recommendations. Still, if you're working off of the J&J vaccine from a booster to the additional dose, it's a 2-month. The other thing that was added in here are the additional doses in here. So now for the age groups, for the quote primary series, it's a 3-dose series, and you can see the time frame there, depending upon which one you use, the number of days in between. And then also in the J&J vaccine, there was an additional dose added in there as well for the immunocompromised patients.
You know, to add to that, Mitch, along with what you said, it's very difficult to define the vaccines of what is severe to moderate to severe immunocompromised patients. When they did the studies and presented the studies at ACIP, they could present it on one type of immunocompromised versus another, but there's not studies in the general population on what it means. So again, they decreased the interval because of the fact that for the most severe immunocompromised people, they don't build as good a response. So they have to give it a little bit more frequently. For someone who has got diabetes and they call themselves quote immunocompromised, which they are to a degree, it may not apply to these type of recommendations for that. But again, as Mitch said, we're not the immunocompromised police. We don't have time for that. We don't have the resources for that. So the thing about this is that we know it is safe if you give it within 3 months.
Okay, did we lose Sandra? Okay, well, we'll keep on talking, Steve, because I think you and I can keep on going forth. So the next thing, Meg, if we go to the next slide, the most recent, and this is one, our team laughed because as soon as I got word of this yesterday, I sent an email with a scream because we were just getting updates, and then all of a sudden this new guidance came out, which really looks at the vaccine timing for certain individuals. And so where it used to be, if you recall, the interval between the first and second dose that we had on the previous slide, where you had either 21 days or 28 days, so either 3 or 4 weeks between dose 1 and dose 2, they actually looked at some of the data in terms of protection. And what they had found is that actually in some patients, and I'll talk about which ones in a few minutes, but extending it to 8 weeks actually gave you some more protection duration. And also looking at the potential for some of the cardiac concerns, that the chances of some of those side effects were lessened as you extended out the time span between your first and second dose. And so this recommendation going from either 3 to 8 weeks for a Pfizer vaccine or 4 to 8 weeks for Moderna is really predicated on several things. An 8-week interval is good for individuals who are 12 years of age to 64 years of age, who really don't have any kind, they don't have immunocompromised conditions. They're pretty healthy. They don't have risks. So those who are 12 to 64 years old, especially the males between 12 and 39 years old, because that was really, as I talked about earlier, really trying to look at the chances of having some of the cardiac side effects that we were hearing reported. Extending that out reduced that incidence, and so that's one of the reasons why they went ahead and put that in there. But if you are immunocompromised, if you are over the age of 65, or based upon the prevalence of COVID in your community, you should then, for those immunocompromised, over 65, or if you have a prevalence of COVID being reported in your community, you should stay with the 3 or 4 week time interval. And so that's a change in the recommendations. As you can see on this slide here, it just was between dose 1 and 2 that changed. Still the interval between your last primary dose and your booster, those still stay the same in terms of, if you're not immunocompromised, it's greater or equal to 5 months. If you're immunocompromised, it's 3 months. So a little confusing when you look at it. We've got this chart. We'll be updating our resources to give you the tools to keep it. I'm recommending to folks now, don't try to remember it. Even folks like me and Steve, who are dealing with this every day, it's even hard for us to keep up with it. And I always have something that I go back and check with just to make sure my brain cells are remembering it well. So I think it's changing. That's why it's so important to keep up and access the resources we're providing, to just double check yourself and put up a chart by your vaccine area so that before you go and vaccinate, you're rechecking yourself.
That's a great.
I think the one. I'm sorry, Senator.
No, I was going to say that's a great recommendation, but I'll pass it to you, Steve.
I think one of the reasons that this is coming about is you have to remember that the goal when the pandemic first started was to prevent hospitalizations and death. And so we had no idea how long the vaccine would last, how to give them when somebody's immunocompromised. We had no information whatsoever. The goal has not been to prevent illness or to prevent transmission. I mean, that's a later goal, but initially it was to prevent the death. So when they came up with these recommendations, it was at first to give the vaccine as soon as possible and get the highest peaks that you can to try to take care of it at that point. As time has gone on now, they're finding out that the duration of protection is affected based on these series. I would have predicted that if they had time to study this as far as the length of series and all, we would have had a 3-dose series period. It would have been like 0, 1 or 2 months and then 6 months, like many of our other vaccines are. But we couldn't do that during the pandemic or during the emergency use authorization period. So I think don't be surprised if we see more recommendations coming on in the future about this information, because it's just as they're gathering the information, they're finding out what it is. So, and by the way, because it's an emergency use authorization, when they did this, they couldn't go back and just say, hey, let's change the series. They had to keep adding to the emergency use authorization. So I think it's just because of the fact that it's new information. They're going to continue to change it and expect more changes to come on.
The other thing to add to that, Steve, good points, is you've been hearing in the media the discussions around potential for a 4th dose, and it's in the works. If I was betting and looking at the tea leaves, I would say we're going to get one. It's part of the recommendation. When, we're not sure yet, but it's coming.
And then are we going to have another variant that comes that the vaccine does not protect against? That may be happening, or will it go away? I mean, it did with SARS-CoV-1. So it's just something we just don't know. We're just having to wait and see.
Yeah, that's kind of unsettling. Just wait and see. Well, we'll knock on wood that we have the latter. So let's go, Mitch, or I have just a question around the new recommendations regarding when patients who have had COVID, when can they receive the COVID-19 vaccination?
So CDC has modified that part of the clinical guidances as well. So if you have active case of COVID, it's defer vaccinations. If you've had COVID, this recommendation still is you get vaccinated and be up to date on your vaccine. So, they've been really playing with the terminology, whether you're, are you fully vaccinated? They've now moved that term away from fully vaccinated to are you up to date on your vaccination? So have you received your primary and booster doses as recommended? So they're now terming it as up to date. So if you've had COVID, if you currently are active in you're testing positive COVID, defer your vaccination. Otherwise, it's okay to get vaccinated. There's no time frame limit there. There is a change in the recommendation where you might recall if you received either a monoclonal antibody or plasma, that there was a wait up to 90 days before you get vaccinated. That has now been removed, so there's not a limitation in terms of when you should get vaccinated, except if you get the Evusheld as part of your pre-prophylactic treatment, you should wait 2 weeks after vaccination to get your Evusheld. So again, what's the value if you have to wait? But that's the one that they particularly mentioned. There's no time limit, no time limitation in terms of if you got a monoclonal antibody, but except for the Evusheld, you need to wait 2 weeks.
Yeah. Well, lots of changing things. So I'm glad we have all of these resources and trying to keep up to date. But I appreciate your previous recommendation of going back, referencing it. Just things are changing so quickly that it's important to stay on top of that. I wanted to invite Dan to the screen here because there was a question around testing and testing positive beyond 5 or even 10 days. I don't know if you could address that a little bit because that's a question that keeps coming up. What should people do? Any guidance around that, and what does it mean?
Absolutely. So this is a great question, and one that is a little bit complicated. So I apologize. I'm going to give a little bit of a longer answer than I sometimes do. So first, I think the first thing we want to understand is the concept of viral shedding, right? So once you've been infected, even after you recover, there is a period of time for which you will continue to shed virus or components of the virus, and it depends on what type of a test you're using to detect the virus. So depending on where you look and what type of a test you're using, there's a pretty good range of how long people can shed virus. So for example, in moderately to severely immunocompromised individuals, they have detected replication competent virus, that's meaning full virus particles, up to and including 20 days and more than 20 days in those individuals. So it would make perfect sense in that kind of a situation that you would continue to test positive 5 and 10 days after your initial infection, and even after you recovered from your clinical symptoms. So that's the first piece of it. In other people who are immunocompetent, the thing to keep in mind is that the virus particles in particular are detected for quite a long time. So there's a great article in the Lancet. I'll drop it in the chat for everybody when I'm done speaking. But the virus particles, and by virus particles I mean viral RNA, or sometimes even virus pieces of protein, like on the protein coat of the virus, can be detected for extremely long periods of time, upwards of 80 days, depending on where you're sampling from. So the longest period that they saw, I think, was actually coming from stool, and they detected detected RNA from COVID-19 120 days out from the initial symptoms. So understand that's how long it can float around. Now, going back to the types of tests that we're most commonly using in the community, those are going to be either PCR-based tests or antigen-based tests, so the rapid tests that you'll see in community pharmacies. So For the PCR-based tests, those are looking for viral RNA. And so, as we just mentioned, that can stick around for quite a long time. The sensitivity of those point-of-care-based RNA tests, the PCR-based tests, is not quite as sensitive as like the full-blown laboratory tests that you take into the hospital labs. However, they're still pretty sensitive. So it's not uncommon at all to see people continue to test positive 5 to 10 days out from initial infection or even recovery. So how do we interpret all of this? The answer is clinically. So once you have a confirmation that someone has tested positive for COVID, they will continue to test positive for days, weeks, and depending on the sensitivity of your test and the circumstances of their immune system, possibly even months. So clinically, I would say we want to take a look at how they're doing. If they have symptoms, that would be an indication that they should probably, not be in places in public and quarantine themselves to minimize the spread. Aside from that, once they recover and are no longer clinically expressing clinical symptoms, it would be okay for them to try to start to resume some of their normal activities. So a little bit of a long answer, but there's just a lot of different aspects to that you have to take into account. The last thing I'll end with is that it's really important to understand the details of any tests that you happen to be running or receiving as a patient. So if you're offering tests in your pharmacy, it's really important to understand the sensitivities and the way that your test works. Again, is it a PCR-based test? Is it an antigen-based test? And we've also seen some antibody-based tests that are looking for antibodies against COVID. And there, as we've been discussing, the whole point of immunizations is that we build up antibodies. So again, depending on the particulars of an antibody, you could even start to see some false positives in people who've been vaccinated. And I would certainly anticipate that once they had antibodies, they would continue to have antibodies for a long duration. So really important for us as pharmacists to be understanding the details of the tests that we're offering to our patients. And on the flip side, if you happen to be the patient, it's always a good idea to ask some questions about the tests that are being performed on you, so you understand exactly what's being tested and what's being assessed.
Great, and there's just a quick follow-up on this. So if people are still testing positive, do you continue to recommend to wear a mask? Are you coupling it up with clinical symptoms?
Yeah, I think that's always a good idea. As I mentioned up front with that example for immunocompromised individuals where they had people shedding replication competent virus for up to 20 days, for 5 to 10 days out, it's pretty reasonable that we would, even as a healthy individual with a normal immune system, that you could be shedding replication competent virus. So to protect those around you, if you need to be out and about, definitely continue to wear a mask.
Great. Thank you. Well, that was great. Thank you so much. And we'll look forward to the reference that you post in the chat.
Absolutely.
All right. So we'll jump over back to you, Mitch, to talk a little bit about parents with children under the age of 5 who've been anxiously awaiting for the EUA on the approval of vaccine for kids. Can you provide an update on that? What's been going on? I know there's been quite a bit of back and forth on that, and people waiting and being somewhat disappointed at the delays on that.
Okay, sure, thanks. So in terms of the under 5 recommendation, you recall that FDA had scheduled the VRBPAC to actually look at the clinical data that was submitted by Pfizer for the 2-dose series, knowing that there was still work being done on a 3-dose series as well. There was some question, evidently, in terms of the data that was there. Was it complete enough, or did they really want to take a quick, more thorough look of the 3-dose impact as well? And the decision was made to hold off and look and get more data to look at the effectiveness of a 2-dose and 3-dose series in this population. And one of the things that was a good thing for waiting is, what was going to happen is we were going to start down the route of getting people vaccinated with the 2-dose, and at some point in time, they would then consider and potentially move to a 3-dose. What impact was that going to have on questions from the public, confidence in the vaccine, and those issues? With this population, I think we all as parents are more sensitive to the health of our kids and have more scrutiny that we give to situations, especially our younger children. So that was a good thing from a science perspective, evidence-based, making sure we're looking at the complete picture before coming out with recommendations. So what has happened is they have delayed that review till probably April. And at that time, FDA and CDC will look at the data and look at it from the perspective of the 3-dose series in place. And so in the meantime, while we're waiting for that review to happen and the decision to be made, pharmacy practices should start having discussions. You need to have discussions within your teams to say, are we going to do something in this area? We've got a pulse survey that is still in the field that closes next week, that we've actually asked the question of pharmacists about, what do you plan to do if the recommendation comes in for those under 5 years of age? And I took a look this morning at some of the preliminary results, and it looks like it's a 50-50 split in terms of pharmacists who will be willing to offer under 5 years of age and those who will stay with 5 years and above. And so it's not a bad thing, I think, because we never want a practitioner to do something that they're not comfortable with. And so that's why we're really encouraging management and the practitioner teams to have those discussions about what will we do, how will we provide it, what age limit will we go down to, and how will we manage it, and who do we partner with in the community. So whether you do it in your own practice or you collaborate with your pediatricians and other physician providers in your community. In some cases, I've heard that there are pharmacy practices who are collaborating with their pediatricians' offices to actually work with them on offering it to those practice patients, whether they're doing the vaccinations actually in those offices or they're helping with the preparation of the vaccines. There are numerous ways we can collaborate, but the key thing that we all need to do as providers is give consistent messaging. We need to understand when the data comes out and the recommendations come out and how to help, because the first place a lot of these parents are going to go is call the pharmacy, and that means those phones are going to go crazy again. But if we can do some preliminary discussions, how will we approach, how are we going to manage, who are we going to recommend, if we're not doing the vaccinations, who do we connect with in the community? Those are important discussions that can happen now and need to happen now.
Oh, that's great.
One of the things that we take a look at with the dosing of this stuff is it's a balance when the manufacturer tries to decide what kind of dose they're going to use in children. Are they going to go with a higher dose to get a better effect? Are they going to get a lower dose where they actually have fewer side effects? And so when they choose that particular dose, and particularly with kids with the mRNA vaccines and the potential for myocarditis, they're trying to be more cautious. So it's not surprising that at that point they would have less of an immune response in that age group because they're trying to be more cautious with the lower dose. So there's a lot of discovery that goes on during that time, and it's just a guessing game.
And there's a question here, whether if there is a history of myocarditis, is this contraindicated to get vaccinated with an mRNA vaccine?
It has more, correct me if I'm wrong on this, but it has more to do if the myocarditis was caused by the vaccine or did they have a case of myocarditis prior to having the vaccine. And so if they've had a case of myocarditis due to the vaccine, they're not to get any other doses. If they've had a myocarditis that was caused by some other natural cause, that is not a contraindication to getting the vaccine. Correct me if I'm wrong on that, but I think that was the recommendation.
Okay.
Yeah, I think you're right.
Okay. I am looking at questions that are coming here, so I'm going to ask this one. I have a doctor who wants Menectra for her senior patient, but the label says up to 55 years only. Am I still okay to inoculate the patient as it is an order from the physician?
What was the vaccine again?
Menectra?
Maybe you need your legal people on for this one.
It's one way of looking at it, Steve, is it's off-label use. The question is, will anybody pay for it? But I think it's a professional.
These are difficult areas. Pharmacists really try to go by ACIP recommendations, and so to do it, but we can fill prescriptions off-label, but not for COVID. By the way, you cannot do an off-label COVID vaccine because of the emergency use authorization. But it's always a tough situation. I think it's always worth discussing it with the provider. And if you're going to fill it, and also keep in mind, like Mitch said, you may not get paid for it.
Yeah, definitely have a discussion with the prescriber. Why, what do they have that rationalizes that use?
Mm-hmm. That's a great thing. So I'm definitely welcoming anybody. If you have any questions or thoughts, please put them in the sidebar here. I do want to go back an off-label question. If parents are coming in requesting vaccine for children under 5, how should pharmacists address that? Because parents might be getting impatient with waiting there. Any thoughts or pointers?
So from the agreement that that providers have signed with the CDC to gain access to the vaccine, we have to follow the CDC recommendations. And so we can't, even if a physician writes a prescription, we can't, in accordance with that agreement, we can't go outside of the CDC ACIP recommendation. So that's the limitation on it. Again, even though if they come in with a prescription, we don't still have the authority to administer it. And even physicians don't, because they're signing the same agreement that pharmacies are. All providers who get the COVID vaccine are signing the same agreement, which says they will abide by the CDC recommendations.
And the CDC or whomever the authorities are said that they will remove your permission to give vaccines if you go outside of the recommendations. So I think the big key on this one is just educate the patients and their parents.
Mm-hmm. Very good. And I have a question here in the sidebar. It says, if a patient age 55 gets Prevnar 20, then do they still need Pneumovax 23 after the age of 65?
Not yet. First of all, that they shouldn't have gotten at that point. I will tell you that. Well, let's take it back. If they had like some chronic disease or something like that, diabetes, that type of thing, it would be quite rational to have it. And so right now there are no recommendations for another vaccine following getting one of the conjugated vaccines. So not now, but again, this is something we need to watch because they haven't really done much discussion on that yet.
Thank you.
If you get the PCV 20 after age 65, you don't get another vaccine either. So.
Okay. And then there's a question here. If you have a 16-year-old patient and they're COVID positive and asymptomatic a week ago, what are the guidelines as a pharmacist for their boosters?
It's also not symptomatic, vaccinate.
Perfect.
Now, one thing to always though tell the patient though, if they've had COVID, that their reaction could be heightened. Not that it's a worry, just again, making them aware that they could have more of a sore arm, more of a reaction to it. Doesn't mean it's harmful, just make them aware of it. That's
good to know. And then the last question I see on the sidebar here is, do either of you have comments regarding SARS-CoV herd immunity?
Herd immunity? That's something that they don't really talk much about right at the moment because we still want to get people vaccinated. And we do know that I don't want to talk about it. I haven't heard the information on it. My guess would be that we have a significant number of people that have either had vaccine or have had the disease. What makes herd immunity, again, maybe Dan knows more about this than I do, but the point of it is that herd immunity is not a reason not to get vaccinated. So there's not a lot of discussion from that route because vaccination is the most important aspect to it. But again, as these states are starting to decrease their distancing and masking guidelines, we'll find out how much herd immunity we have.
Great. And then there's just a clarification here. I just wanted to confirm I heard you correctly. You said that if a patient receives PCV 20 before age of 65 for underlying conditions, there is no recommendation right now to receive another pneumococcal vaccine after age of 65.
That is correct.
Okay, so it's confirmed. Very good. Let's see, I've got one more question. I saw that new guidelines for male patients of age 12 to 39 years to space a second dose at 8 weeks instead of 3 weeks. What reason am I telling the patient to come back in 8 weeks?
The reason that they did it for that age group is to reduce the incidence of the myocarditis potential. And so that's the reason. Not that, you know, you can't do it earlier, and they just saw, and people, even at 8 weeks, you could still get cases of myocarditis. Your incidence rates, though, what they found can be lessened by extending the time frame. So that was the rationale for picking out that particular population.
And it's a period of duration. It's not an absolute 8 week, 3 week type of thing. So it's up to, just use discretion, is I think what I can tell pharmacists.
Yeah, and I would say if you've got any concerns that a patient not coming back during that time, vaccinate. You know, that's with everything with vaccinations. I don't say everything. That's with most of the vaccinations, is if you're in doubt that they're not going to come back, you know, the leaning is always, you know, give it to them if you don't think they're going to come back. We did have that come up every time in flu season. What's the right time to start administering the flu season? Again, caveat always from CDC is if you are concerned about them not coming back, take advantage of the opportunity.
Very good. Well, with that, that's the end of all the questions that came in. I really appreciate you, Stephen and Mitch, for going over all of the latest breaking news. It's so much to keep up with, and really appreciate all the detail, attention, updates that you have provided to us today and that you continue to provide. So thank you so much. Really appreciate it. What we'll do next is we're going to speak about what's going on with APhA and what's coming up. And so with that, I'll invite, let's see who we've got here. Mike Baxter, we'll invite you to turn on your screen here. So I will pass it over to you for the advocacy update.
Sure. Well, thank you, Sandra, and welcome everybody. Another very busy week in advocacy as well at APhA. This week, our CEO, Scott Canora, has invited to a roundtable with the HHS Secretary. So we want you to know that we'll get your recommendations. You know, the people we're meeting with, the policymakers here in DC, we go right to the top to have these discussions. Most recently, we met with the HHS Secretary, Javier Becerra, at a roundtable to discuss increasing routine vaccination rates and promoting health equity. As you know, two big goals for this administration and for pharmacists. We went through a number of things where we agree, and we're really excited that, you know, the secretary, when he thinks about pharmacy and pharmacists, picks up the phone and calls us. We're the only pharmacy representatives in the meeting. We were there with the school nurses, the pediatricians as well, and a bunch of public health advocates as well for immunization rates and increasing them among populations, including adults and children. A few key factors that we agreed on and pushed on, you know, increasing, getting better data out there, particularly with the health equity efforts that are going on, funding and incorporating pharmacists into information immunization systems that are going on in the states and making sure that we're incorporated part of the immunization neighborhood and team going forward. Also, we brought up a recommendation you may remember with COVID. They actually pay us an additional $35.50 adjusted by geography to bring those COVID vaccines to populations that can't get them. So we recommended doing that for other routine vaccinations as well going forward. We did get some kickback back, though, saying that since the Build Back Better Act hasn't passed, there's a provision in there that we do support getting rid of the co-payments under Part D for folks to receive vaccinations, but it hasn't passed. It's been stalled in Congress. So they did mention that the funding is kind of running out for COVID right now. One concerning thing is obviously the temporary authorities that we have, since we're talking about vaccinations today. One of those, the COVID-19 vaccinations, the authority to vaccinate ages 3 to 18. These are all under the PrEP Act, right, which came out, which is a federal law that kind of allows us to provide these counter cover measures in times of public health emergency. And the president actually recently just renewed the national health emergency, which is kind of the first step to giving us that authority. That second step from the HHS secretary, we're still in right now for the most recent extension. The disaster declaration that has to be issued to give us that authority. That's up April 15th. So we pressed on that as well. And we said we really need to make these PrEP Act and temporary authorities permanent. We've shown, obviously, that more people get vaccinations and immunizations from pharmacists than any other site of care. The secretary also wanted to increase vaccinations and have more vaccinators, particularly around schools, in anticipation, I think, of the new EUAs that may be coming out. However, we didn't get a firm commitment there. He mentioned that those temporary authorities are temporary, that they will be coming to an end soon, which adds more credence to the fact that we may need a legislative solution to make these temporary authorities permanent. And I'll go to the next slide. And that's why we wanted to mention today, we announced recently this week a new coalition that we formed, the Future of Pharmacy Care Coalition. You can see there's a website there today. There's also the Twitter handle and the Facebook page as well. We're going to putting out information on how federal policymakers can really learn to act quickly to address these current law limitations so that patients can continue to access these essential care services provided by pharmacists. Stay tuned. I'd say log in, follow it, check in on it, like it, because you're going to be seeing not only statistics on the great work that pharmacists are doing immunizing, but also public policy efforts that are going to be coming out, additional legislation that we're going to be supporting. We're really going to need your help, and we're going to need your activism as well. But those are two major updates for this week, and I'll turn it back to Sandra to go over a couple resources.
Well, thanks a lot, Mike, for all you do, and for the government affairs team. I know every day there's incredible updates about all of the work that we're advocating for, so appreciate your time on doing that. So we are going to talk a little bit about the redesigned COVID-19 Vaccine Resource Center. We've revamped the library for COVID-19 vaccine resources, and as you heard from Mitch, there's just so much going on, but we are now organized by topic. So we encourage you to bookmark this page and have it as a handy resource, especially as things get updated and change. This is a great resource to give you the latest information and make sure that you're providing the latest recommendations to the patient. So hopefully you book tag that. It's on, again, it's in the handout and you can link to it that way. I also wanted to talk today about the annual meeting. So hopefully you've registered to attend the meeting in San Antonio. We're looking forward to seeing you live in March, and it's just coming up in the next few weeks here. So please register. There's a schedule of events, a great agenda of speakers, and we are looking forward to seeing you. It's been a while since we've seen each other in person, so hopefully we can see most of you come back to that meeting. The next webinar we will have will be on Thursday, March 10th, and the link for the registration is here on the slide, so you can link through that. We will be talking about more updates, and so there should be more information coming in about the topic of that presentation. It'll be at the same time, 1 to 2 Eastern. And we will also have a recording of today's webinar as soon as possible on our open forum webinar library. And with that, we thank you for joining us today. Stay safe. Hopefully we see you in San Antonio, and we will see you hopefully Thursday, March 10th for the next webinar. Have a great rest of the week, and thank you all. Thank you, Steve. Thank you, Mitch. Thank you, Mike. Thank you, Dan, for all of the information today. Have a great rest of the day.